is, huh? Anybody? Julie, hey, guess what day it is? Oh, come on, I know you can hear me. Mike. What day is it, Mike? Listen, guess what today is?
It's hump day. Ronnie, how happy are folks who save hundreds of dollars switching to Geico? I'd say happier than a camel on Wednesday.
Hump day.
Get happy. Get Geico. 15 minutes could save you 15% or more.
Hey guys, how's it going?
Hey.
How you doing, Jeff?
I'm doing great, and welcome, Dinks. It's happy hour with the Dinks.
In America.
Welcome to Hump Day Happy Hour. Dentists in the know, your backstage look at current trends, politics, and education in the dental world. It's live, and it's over a cocktail. I'm Jeff Horowitz, and that guy, I'm getting good at this now, Chad. That guy is Chad Duplantis. That gal is Jennifer Bell. We're all practicing dentists. We're all catapult educators and business owners. We're here to bring you guys in the know. So how is it going, my friends?
Good. How's it going for you?
Pretty good.
Okay, great.
Do you see my new bookcase?
It looks so familiar.
Does it look familiar?
It does. I can't put my finger on it.
It's very rich looking. I think it's made of mahogany.
It smells of old books.
Yeah. I've got like a signed helmet above me over my shoulder there. I've got lots of cool books.
Didn't even know you were a Texas fan.
Oh, yeah. The biggest by far. Yeah. Chad, you like my bookcase?
I do. Did you steal it?
No.
So I do
Maybe a little.
I do need to tell everybody that for our live platform tonight, we are actually doing a completely new live platform. So if you see me looking here, there, everywhere, we're just trying to make sure that it all coordinates correctly. But so far, so good. Still got to work out a few kinks, but I like it. I think we're going to be good.
I like it too. Good job.
Yeah, thanks.
So what's happening in your worlds this week?
JB?
Well, it's been a busy week actually because we are renovating our office. We've ripped up all the floors. We're putting new flooring in. We hit the 10-year anniversary this year, so it was time to do some upgrades and updates to improve just the quality of our workday, quite frankly, and spruce up the office a bit. So we've been closed. We've been doing staff development, team building. COVID was tough. I think we talked about this a few weeks ago about staff turnover and challenges with hiring. And so today we spent a lot of time in a more social atmosphere, developing some team building amongst many of our new team members with a lot of our more loyal members that are still with us. And so we went axe throwing, which was quite fun, and everybody had a great time. It was nice to feel a little bit of normalcy, even with masks on, but we still...
No spouses, I hope, at the axe throwing event, right?
No,
Okay.
but I can't promise some weren't pretending.
You can really see who has those issues.
Correct. Correct. But anyway, so lots going on, managing the renovation and trying to build some camaraderie again among our new people. So all good things, but
Good.
More time.
Love to hear it, Chatty. What you got going on?
Well, from an office perspective, it's been a great week. We've had some, I guess I would say, team unity. We had everybody's just kind of rallied around each other and picked up the pieces, from one of those weeks that looked like it was going to be kind of slow. It's actually, really picking up and gotten crazy, but we all rallied. Another thing from an office perspective, I think you and I were talking this past week. We signed up with Swell about a week and a half ago, and I'm just amazed at how well it works to gain reviews, and it's just been really a great addition to the office. But another thing that happened this week is I got to spend a lot of quality time with my buddy Jeff.
You messed it up again.
Well, no. Well, I'm the screen I'm looking at. So my buddy Jeff.
There you go.
I guess I got to look at the Facebook feed. But my buddy Jeff came down to Texas. We had a great time. We hammered out some things for DINKS, talked about the future of DINKS.
I got a new bookcase.
He got a new bookcase that he drove back to South Carolina
I was
with.
going to say, how'd that fit in your suitcase?
Yeah,
He
yeah.
told some off-color jokes to my 18-year-old who shared them at the dinner table, which was awesome because now, what is it? What is it that he called you, Jeff? Mr. Dr. Uncle Jeff?
Mr. Dr. Uncle Jeff.
Yeah, so Mr. Dr. Uncle Jeff is a legend of the Duplantis household. So it's really just been a great week. We had a great week.
And what I love is that everything's bigger in Texas, even me. I felt this big in Texas. I felt important.
That's good.
Yeah,
That's good.
no, man, what a great time, and great time getting to know each other's families, and only going to be more and more of that. But we did get a lot of really cool stuff ironed out. Next time JB's going to be with us for sure.
Yep.
Right, JB?
Yes, of course.
Okay. So I got a little bit of good news. I got my lights. You know, the lights that I have complained about for the last 9 weeks that were ordered. I had 2 lights ordered for my one office, 1 light ordered for my main office, and they have finally come in. So they're getting installed this Friday. I'm excited. So I can see again.
This is so exciting. I'm
Is
so
it?
happy for you.
The bad thing was all the patients that have been here for the last 9 weeks.
Hey, Jeff.
Hopefully they're not listening tonight.
Yeah.
I have to tell you that my dog heard your voice and came and was pawing at the door, which never happens during a live cast. And so I mean, everybody knows that Mr. Dr. Uncle Jeff is on the podcast. So
That's funny. Oh, we lost Jennifer.
No, I'm here.
Oh, she's still back.
She had to pick her nose.
Yeah. You can't do that on camera.
That's what you have to do. So, gosh, we got a really great show lined up tonight. It's another killer program. We're going to talk about the joint. No, Chad, not that joint.
We already had that show.
The joint. We're going to talk about the joint. And it's not going to be a boring TMJ talk. We're going to talk about how the joint could be responsible for many of the bite discrepancies that we see every day. So my great friend, colleague, and mentor, Dr. Jim McKee, is with us. Many of you know him as a faculty member at the Piper Education and Resource Center, as well as Spear Education. He's going to be chatting with us a little bit. Certainly, JB, I think you're going to have some news for us. I think Chad's got a little bit of content for us at the end of the show. And but most importantly, it is happy hour and it is hump day. So cheers to you, my friends.
Cheers.
And cheers to all of you out there. What are you guys drinking tonight?
Just a Sauvignon Blanc, kind of my old standby when it's been a busy day and I'm lacking creativity.
Chad?
I'm having a Sam Adams, but I guess I'm going to have to put my rolling papers away since you said that we were talking about
Not
this,
that kind of joint show.
not this joint.
Not that joint. I am
The
actually
virtual
drinking.
It's a napkin.
I am drinking a bottle. Oh, it doesn't show because of my virtual. Now you all know it's virtual.
Put it in front of your body.
Oh, that works.
There you go.
Yeah, that's why Chad's our tech guy. So
Yeah.
I'm drinking a bottle of Machete by Oren Swift tonight, and I am very much enjoying this. So yeah, and I just dropped something off my desk. So it wasn't the wine though, so that's good. So with that, I think we are ready for some news. Why don't we hand it off to JB, and why don't you tell us about what's going on in the dental world?
You got it. Well, you know, as we've talked many weeks now in a row, the legislative activity has slowed somewhat because of the election and new people coming and going. So there's not a ton of activity, but there are 2 Senate bills that are that have come up that I think have drawn some interest in the dental community that we should be watching to see how it progresses. The first one is Senate Bill 4894, which is a Senate bill to have very clear language in dental and optometry for fee setting by insurance carriers for non-covered services. So how that translates in our office is a service that's not covered by a dental insurance provider the legislation would allow you to set your normal fee for that as opposed to your contracted rate. There's a lot of nuances with that particular catch, if you will. I live in a state where there is legislation on a local level that prohibits insurance providers from dictating fees for non-covered services. That was a big win for us a few years ago. But I still see that language being communicated on EOBs going out to patients. There's a little bit of a quirk that the insurance providers are using, and it basically states that if the service is covered in their plans, but just not covered for that patient, then it's still a covered service. And so then they can dictate the fee schedule for that particular patient. I don't know.
Kind of crazy to me.
You know how things go. So
yeah.
I don't know how this particular bill will affect that, or if it will make the language more clear. I do know that if it's a Senate bill, it will help some of the state by state nuances that currently exist, where some states have that type of legislation already in place, and some have not been successful at getting that in stone for their particular dental law. So it would be nice to have something on a more federal level that sort of dictates how insurance companies can behave. So that's one of the Senate bills. The other Senate bill is 4608. This one's kind of a fun one because
Chad 4608. You remember that one?
Yeah. Highlight it.
Yeah. 4608, 4609, whatever it takes.
We've been tracking that one for years now. This one is for military spouses who have professional licensures. So if you are the spouse of a military office member or servant member who is getting relocated to different states and you want to perform your professional duties in other states, this bill is looking to help offer reciprocity for spouses of military members to be able to practice in other states. So obviously this relates to dentistry as well as many other professional services. It looks like it would be maybe a better fast track for reciprocity for those individuals. We know their stays are often short, and a lot of states have very particular rules about how reciprocity is given for individuals coming in with different licensure. So perhaps maybe this will make it a little bit easier for those individuals to find work as they are being dutiful and following their spouse member from base to base or locale to locale. So that's kind of an interesting one.
Let me make sure I understand this. So if I sign Ginny up for the Army and she gets stationed in North Carolina,
correct,
then I would just have a fast track to reciprocity where I could come and practice with you a little bit.
That's correct. Oh gosh, wait. I feel like Ginny just got signed up for the military.
Or maybe I just signed Ginny up for the axe throwing. Okay.
And let me just tell you this, Jeff, that if you sign Ginny up for the military, whether it's House Bill 4608, 4609, 4607, she's going to kick your ass.
Yeah, that's 100%
Yeah.
true.
That could happen on any given day, any given moment.
That's Horowitz Bill 4608.
She doesn't need military training for that. That's
I think
just a
that
day in the
bill
life,
was
buddy.
covered a long time ago.
That's just a day in my world.
Yep.
Sorry, JB. I feel like
no, you're fine. So the next one that came up it popped up on the ADA website. So now there is apparently a very credible threat to U.S. hospitals and healthcare facilities relating to ransomware and a cyber attack. And so first, I would say just make sure that all your security is buttoned up, that you're working with IT professionals to make sure you're protected. Educate your staff members on staying away from personal emails and social media accounts on your internet within your office and your network so that they're not putting ransomware incidentally on there. It sounds like this was a pretty well vetted attack. They have proof and evidence that it's being attempted. So just be mindful. And then obviously they recommend to not pay those ransom requests. you likely will lose that data should they compromise something within your network. You know, this is kind of an interesting anecdotal story, but I don't think practices really realize too how vulnerable their Wi-Fi system is. You know, a lot of us market and advertise that we offer free Wi-Fi for our patients when they come in, if they're sitting in the waiting room, which doesn't really happen anymore, or, you know, or in the operatories. My IT person had a doctor, this has probably been about a year ago, but when ransomware was really starting to kind of uptick a bit in the healthcare world, he had a doctor who had a patient come in, sat in the waiting room, popped online, got on the Wi-Fi, the free Wi-Fi offered to guests. That individual happened to have a malware virus on his laptop, didn't know it at the time. It got onto the Wi-Fi system. There's a malware virus out there now that once it gets on the network, it's designed to get into anything that's connected to the Wi-Fi. So he actually lost his iTero and he lost his Omnicam because it got into both of those devices because they were also using the Wi-Fi. So since that time, we actually shut down all of our guest Wi-Fi. Our staff uses cellular service if they need to connect, and we encourage our patients to do the same. I know that's probably a bit dramatic, and some people might not feel that that's, you know, quite necessary, but we use a lot of the milling stations and the 3D printers and iTeras and everything are operating off of our internal Wi-Fi system. And so we just needed one more additional level of protection. You know, that gentleman who sat in that waiting room had no ill intent. He didn't know it was
No, it was just there. Yeah.
Correct.
Yeah.
So just, you know, food for thought on that one.
That's kind of crazy. So the faxes that come through from Uganda that say that there's a long lost relative that has an inheritance sitting in a bank account.
Yes.
Should I not be providing my checking account routing and account numbers to these people?
I think that's all good. Just don't give them your SOC. You know,
Okay.
like give them your bank account, your debit card, you know, your mother's maiden name.
You see, Chad looks real. Chad is starting to look worried.
He looks genuinely concerned. He's thinking, what's going on with my internal network system at my office? And JV and I are going to have a chat after this.
Well, you were talking about, I got one from Canada today, and it was talking about my great grandfather, and I had an inheritance on some oil land up there. I went ahead and gave him all my information.
I think that's perfect. That seems very legit.
Okay. Because I mean, the reward was too great. You know, so
oh yeah.
I just did it.
And obviously, if they knew your name, they had to be legit, right?
Well, that's what I said. It was just like, you know, yeah. So I'm glad that that's okay that I did that because I gave them everything today. So
I own 20 Nigerian princesses. Yeah, I've gotten so many emails. I've saved them all from captivity. So
that's awesome.
I know. It's been, you know, you do your part. You do what you got to.
You got to do what you got.
All right. So on the last one, we'll end on a nerd note. New York, NYU College of Dentistry released a study this week on a pain score being attached to the likelihood that oral cancer being found is metastatic. So I thought that was kind of an interesting piece because I think well, I remember when we were educated on cancer, that pain may or may not be a predictable factor because as cancer spreads and grows, a lot of times it kills the pain receptors. And so you couldn't really rely on pain as being, you know, a categorical diagnostic factor of whether or not it was cancer. But in their study, they found that lesions that were identified based on the depth of the lesion and the pain score that was reported by the patient would often be a predictive factor of whether or not that cancer had metastasized and then later confirmed with other diagnostic tools. So they're looking into this more. Obviously, they're recommending additional studies to find new information related to that. But, you know, I think all of those things continue to help us be educated clinicians and providing the best level of care for our patients. And I'm grateful that people continue to research and look into those areas that, you know, of all the many things that we treat, Jeff, I think sleep apnea falls in that category, but oral cancer is, you know, one of the things when we identify it saves lives. And so, you know, it's important that people are continuing to research and give us good operating data that we can take back to the practice every day.
No,
that's all
huge.
I got.
No, that great stuff. I know we had a slow week last week in the news, but
Yeah, you never know.
man, you brought it this week.
I could not make a 24-hour news cycle out of dental news. I can assure you of that. But you know, I could do a
All
15
Dental
minute.
News Network, the DNN.
Yeah.
Oh, I think it would be a huge hit, you know?
That is a must. I think that we need to
Oh, sure. Right. Yeah,
go
yeah,
down
yeah.
that rabbit hole.
Yeah.
I'm not sure that we're gonna do that.
Senate Bill 4289. What's next?
Yeah, and now we're gonna play a rerun of the Jerry Lewis telethon from 1974 because we're out of stuff.
Come down to and old lectures from whoever in the 70s. And
All right, let's do so. Let's bring Jim McKee on. What do you guys say?
Let's do it.
I think that's a great idea.
All right, let's do it because this guy is one of my favorite people in dentistry, and I think you guys are gonna see why I think he's one of my favorite people in dentistry. Jim McKee's maintained a private practice in the greater Downers Grove area. Like, is that how the greater Downers Grove metropolitan area in Illinois?
I'll take that.
Since 1984, he has he's very experienced in treating a wide variety of cases with a focus on predictable restorative dentistry. Many of you know Jim as an American Academy of Restorative Dentistry member, maybe as a former president of the American Equilibration Society. Jim lectures all over the place, nationally, internationally. He's been at it for more than 25 years. He directs many study clubs, including the Piper Study Club, which I am so fortunate to be a part of. And actually, that's how I got to know Jim. But he also serves as an instructor at the Piper Education and Research Center, as well as for Spear Education. Dr. McKee, excuse me, graduated from the University. What's that Irish school? Notre Dame.
It's the one that just beat Clemson.
Showing. He graduated from Notre Dame in 1980. He earned his dental degree from the University of Illinois. And we are so thankful that you've taken some time to join us and to see my new bookcase, Jim.
I love your bookcase, by the way.
Yeah, it rocks.
Chad, you ought to think about that. Have you ever looked at that bookcase? It's really sharp. It might look good in your house.
Hey, you know what, Jeff? Why don't you go back to your bookcase?
I am. Look, I'm grabbing a book.
And why don't you grab something?
I am. I'm grabbing a book right now.
Yeah. That's about the only thing that Notre Dame owns in my book is my Texas Longhorns.
I got this.
Well, funny you should mention that. In 1978, when I was a sophomore, they played Earl Campbell.
Oh,
when
really?
Notre Dame was number 5 and Texas was number 1, and Notre Dame vaulted to a national championship that year.
Yeah, Notre Dame's pretty good.
38 to 10, if I remember correctly.
It's when Texas is on their schedule.
Yeah. They tend to rise to the occasion a lot of times. So, Jim, thank you again for coming on. And, you know, as I said to most of you, I first met Jim at the Piper Education and Research Center in St. Pete, Florida. Many of you who have heard me talk on this channel and in other outlets, that my road in education has been that I had a life of continuum learning, orthodontic, TMJ courses, but I never could reconcile why, despite my best efforts, some of my functional and rehabilitation cases were still failing, despite the continuum education, despite all of these courses that I had taken in ortho and TMJ. I really thought that I was well-rounded. So Jim, along with Mark Piper, continues to be my mentor and help bring the dental world together. So, you know, Jim, you're actually in my lectures, whether you know it or not. I actually have a slide of my dental heroes, and you are one of them. Not just because of the knowledge that you bring, but because of your giving nature, that your love for discussion and the fact that there's nothing in that big old noggin that you don't want to share. So before we get really too deep, I think the most important question is, what are you drinking?
Well, first of all, thank you for that wonderful introduction, Jeff. I am truly humbled, and it is really an honor for me to be here. So thank you so much. And your second,
welcome.
I have a glass of Pinot Grigio going, a San Margarita version. So I thought that could take us nicely through our discussions tonight.
Fragile must be Italian.
Nothing gets past that guy.
All right. Well, cheers, Jim. Thanks for being
Cheers.
with us.
Thank you.
And I hope your week's going well. So, Jim, at the Piper Center, and I want to really introduce the DINKS to something that we call foundationally based diagnosis. And really, that was the point at which I felt my dental worlds began to come together, where I could take all my education from the Coy Center and all the old TMJ training that I had and the orthodontic training that I had. For the first time, I could really feel everything coming together when we began at the Piper Center discussing foundationally based diagnosis. So for everyone out there that may not be familiar with that term, would you mind giving a brief explanation of what that means and what the thought process is there?
I would love to. It's interesting because, I got into this as a restorative dentist. A lot of times when people talk about joints or TMJ, it's because of pain. Because as a profession, that's kind of how we've defined TMJ patients, or pain patients. By the time patients have pain, it's almost always the end stage of the problem. And quite honestly, most of the complicated cases that we see from an occlusal perspective have a joint issue with them, but many of those patients have adapted. So really, I think Mark Piper is the one that really developed the term foundational occlusion, which led to foundationally diagnosed dentistry. And really, because ultimately when we talk about occlusion, our typical definition of occlusion is how the teeth fit together. I mean, that's how we were taught. In angle class 1 occlusion, you look at the molars and see how they fit together. If the mesiobuccal cusp of the upper first molar is in the central groove of the lower first molar, it's a class 1 occlusion. It's all tooth-based. The problem is, if you really look at the anatomy, though, the teeth are one part of the articulation. But if you really look at an occlusion, it's the articulation of the lower jaw against the upper jaw. And all of a sudden now we have 3 points of articulation. We've got the teeth, but we also have the right joint, and we also have the left joint. Well, like most of you, I really was trained at the tooth level. I mean, my training in dental school in TMJ was nothing. I was taught that these people were crazy. Why would you want to treat them? Because again, those were the end stage pain patients that had never been diagnosed. So as a restorative dentist, what I started to see was the same thing that Jeff did, was that I had restorative cases that weren't stable or didn't go the way I thought they would. But the problem was, I knew I got the teeth in the right place. But the problem wasn't at the tooth level, it was at the joint level.
Yeah, how many times can you equilibrate, Jim, right?
That's the problem. I mean, but ultimately, I was really fortunate because I heard Pete Dawson. I was 5 years out of dental school, and I heard Pete talk about occlusion, and it totally made sense to me. A year later, I saw Mark Piper at a hands-on course at Pete Dawson's teaching center, and the joints made sense to me too. So from my perspective, I kind of learned occlusion and TMJ together. And while Mark is known as a surgeon, I honestly believe that Mark's greatest contributions to dentistry have really, I think, been in terms of risk assessment, tying into what John Coyce talks about, in terms of bringing risk assessment to the TM joint in terms for the restorative dentist. That's the part that I think, as a young dentist, I want to learn, because those were the lessons that I learned later in dentistry. And quite frankly, those were the harder lessons to learn. So I guess foundational foundational diagnosis means really diagnosis from an occlusal perspective at the 3 points of articulation, at the teeth and at the joint level. So I guess that would be my way I would describe it.
No, I think that's absolutely perfect. And I think that in dental school, many of us are taught that the occlusion is actually the malocclusion is usually the diagnosis instead of perhaps the symptom of a greater problem.
That's a great way to say it. And really what we think the tooth malocclusion caused the joint problem.
That's how most people were taught.
We're looking at the wrong end of the horse.
Thank you. I just brought you on for validation.
And really what it comes down to is vertical dimension. You know, it's funny because when dentists talk about vertical dimension, dentists are always nervous about talking about vertical dimension. You know, the question becomes, if you have to increase the vertical dimension in the case, how much are you going to feel comfortable increasing it? 2 millimeters, 3 millimeters, 4 millimeters. Most people wouldn't feel comfortable opening the bite 10 millimeters, right? The problem is we see changes in vertical dimension at the joint level that are that magnitude or greater, but we think it's a genetic problem. We think they're born with a class 2 occlusion. We think they're born with a facial asymmetry. This is an acquired defect. And that's really, I think, in terms of what Mark talks about, the foundational discussion, because we tend to look at things at the tooth level. And I think one of the greatest things that Mark has taught me is to ask the question at a deeper level. The occlusal problem starts with the joint level.
Right.
That's the part we need to get the message.
So exactly. So not necessarily how are they presenting, but why are they presenting that way? I think that's the question that we need to be asking.
Exactly.
So let me take that a step further and say, so you think about, you know, you just mentioned that it's not uncommon for someone with a significant temporomandibular joint injury to present with, you know, a ramus height discrepancy from the left or right side of 10 millimeters. We see it all the time. And my contention is one of the best ways to find that out immediately is to be routinely taking cone beam images on our patients. I am a huge advocate of taking cone beams on every single new patient. So I'm curious as to what your thoughts are about imaging, how important imaging is to general dentists, how important it is to have that kind of technology in your practice as a general dentist, and what other types of imaging are available for us to maybe find out at the beginning of the case if they have a problem or not.
I don't really use imaging, so I can't address that.
Well, thanks for being with us. It was a great evening. We hope you'll come back sometime.
That makes me feel way better, Jim, because you lost me at Ramus a minute ago. I'm glad to hear that.
Here's the easy discussion about imaging, because everyone gets wrapped around the actual when should I image, who needs to be imaged. It's the same thing. I was doing a lecture at a Spears Summit meeting 2 or 3 years ago. And a woman came up to me and said, I'm really nervous about treating TMJ patients. And I said, I totally get it. I said, do you do endo? And she says, I love to do endo, and I'm really good at endo. I said, a patient comes into you with a carious exposure on number 14. They want to keep the tooth. Are you confident doing the endo? She goes, yeah. I said, what if your X-ray machine was broken and you couldn't take an image of the tooth to see the root length or the root anatomy? She goes, I wouldn't start the root canal. Ultimately, imaging is about risk assessment. That's what imaging is about. So we're not going to image everyone, but as a restorative dentist, it's the same as if they have periodontal pockets with bleeding. It's the same if they have failing restorations, it's risk factors. So the question is really, what's the threshold when you're evaluating occlusions and joints to want to get an idea of what's happening at the imaging at the back end of the system? That's really what it comes down to. And ultimately, it's two reasons. It's either something doesn't fit or something hurts. So those in terms of imaging, I look at the CBCT for the hard tissue and I look at the MRI for the soft tissue. And if I can put those together, I'm really confident talking to a patient about whether an occlusion is going to be stable for a restorative case. And, you know, really, I do imaging in a little different perspective, because most of the time when you hear imaging, you're going to hear from an orofacial pain perspective. It's about how to treat pain patients. That's not primarily why I'm imaging. I'm a restorative dentist. I'm imaging to assess stability in the occlusal reconstructive work that I'm doing. Because so many of the cases that we see that are the tougher cases, and quite honestly, if you're on a site like this, if you're going to John Kois's programs, if you're going to Frank Spear's programs, you're going to see those types of patients in your practice, because those are the patients that are going to self-select you, because you're going to offer expertise that's generally higher than the community standard. So they're going to find you. And so many of those patients have high-risk joint issues that I have found that those types of practices that really implement the concepts that are taught at some of the places that Jeff talked about develop more of an imaging practice, because they're seeing those types of patients more routinely. And what it comes down to is, you know, really the reason I started imaging, because I got tired of writing refund checks.
We're good at that.
I have a question. So thank you for calling on me, Jim. Appreciate that. It would have taken all night if I was waiting on Jeff and JB.
Valid.
So how often,
Texas,
because stop it, you two. First of all, you know, I have a CBCT in my office, and I do take CBCTs fairly routinely, but MRIs, and I think that those are really crucial, and that's maybe a missed aspect of dentistry, because I think you mentioned that briefly, but are you sending patients to a specific center for that, or are you prescribing this regularly? Because I really think that now that I have the CBCT, gosh, I'd love to have the capability to take some sort of MRI with the same technology in my practice. So
let's talk about that for a minute, because really MRI has become the stepchild of imaging, because CBCT has become so prevalent. I mean, honestly, you know, I come at it from a different angle, because when I started imaging, MRI was the only thing that was available. You know, I heard Mark speak in 1990, and I took my first MRI in 1991. That was before cone beams were out there. So for years, all I had was MRI.
You didn't have an axiotome, Jim?
I had a transcranial.
I had an axiotome.
Yeah,
Thing was a beast.
Yeah, I had the transcranial, and I had the Panorex, the Panseph units. But ultimately, here's the problem why dentists are uncomfortable with MRI. Because ultimately, what does MRI image? Soft tissue. Soft tissue. The dental community assumes the disc doesn't have a very important role, because it goes back to what I said before. When the dental profession talks about TMJ, they define it as pain. But when you think, and the problem is sometimes people who have clicking joints don't hurt. So all of a sudden, if the only problem is pain, then you don't have to take an MRI. But if you think about what the disc influences, first of all, the disc is going to influence growth. We know by clinical studies and in peer-reviewed literature articles that if the disc comes off before growth is complete, there is a higher likelihood that the bone doesn't grow to its full genetic potential. And ultimately, that results in a class 2 occlusion. How many of the difficult cases in your restorative practice have class 2 occlusions? It's a pretty high percentage of them if you think about it. The disc influences facial development in terms of growth. It influences airway, because if the disc comes off, we have a loss of vertical dimension of the joint level, which is a negative airway impact. it impacts pain, it impacts all these different things, but because some patients don't hurt when they click, MRIs aren't necessary. The problem is if we wait till we see it on a CBCT, we miss the young kids. Jeff Rouse and I are good friends, and I know you know Jeff well. Jeff and I, we just did a webinar titled, "Are we treating the same patient?" The airway joint patient is the same patient. And the problem is they both start way earlier than we thought. Jeff says kids shouldn't click, or Jeff says kids shouldn't snore. I'm going to say kids shouldn't click either. And kids shouldn't have pain in their joints. Either one of those are really setting up an entire lifetime of dental problems. Those are the patients that are the tough cases. So for me, I generally will send to an imaging center. You have to, I think today, part of your interdisciplinary team has to be a radiologist. So if you can find a radiologist at an imaging center, they will cater to you because they want your business, quite honestly. So I try to find a non-hospital based imaging center, if possible, to work with one radiologist. So I have a certain number of techs who are trained. And for me, it's worked out really well. So my diagnostic protocol, I get both of them together because basically what you said, if I only get the CBCT, I'm guessing at the soft tissue. If I only get the MRI, I'm guessing at the hard tissue. And the more complex the cases that you see, I don't want to guess. That's why I end up getting both of them. From a practice management perspective, let me just drop a little practice management in for a second. When I first started doing this, it was difficult to generate profitability because my new patient exam didn't match the amount of time I was putting in to developing the case diagnostically. When I started doing a 2-appointment exam process, where I would do an examination at a relatively low fee per hour production, and then create value for a diagnostic records appointment that was a higher production per hour, when I combined the time between the exam and the diagnostic records, the numbers came out the same whether I was prepping teeth or diagnosing occlusal problems. Lisa was giving me a hard time. My wife's saying, sometimes I hear your gums running more than the handpiece. If you can get your numbers to the point where you can be able to do the same thing either way, think about it from the patient's perspective. Mark Piper said this a long time ago, the most expensive thing a patient can do is not get diagnosed. The number of patients that I can see coming in on a weekly basis who have spent thousands of dollars on treatment that had no chance of working because the anatomy wasn't assessed is astounding. The best thing we can do for our patients is to diagnose the condition of their joints in the type of patients who need that. Like I said, not everyone needs that, but it's generally—
Jim, I'm going to stop you there. I'm going to make you say that again because this is the number one pushback we hear about MR imaging and owning a CBCT is dentists who feel that they are unfairly charging patients for tests that they may not need. When in actuality, even if they spent $800 or $900 on an MRI and $300 to $400 on a CBCT, what is more expensive?
They spend
that or $25,000 or $30,000 or $40,000 treatment plan that cannot work.
they spend more on the splint than they do on the diagnostics.
Mm-hmm.
I mean, that's the problem. Because we've devalued diagnostics. Why have we devalued diagnostics? Because insurance doesn't cover it.
Right.
Ultimately, dentists don't want to have the difficult discussion because we all fear rejection. Right?
Yeah.
I mean, that's the problem.
How much are you seeing medical billing starting to come into play with, the types of diagnosis and diagnostic testing that you're doing? Obviously, the CT and the MRI would likely fall under medical, but your exams and those types of things related to TMJ diagnostics and management, Are you seeing medical billing starting to play more of an active role in your practice or in the field in general?
You know, that's an awesome question, and I have a really interesting answer on it because
Okay.
for years, what we tried to do was I never wanted to bill medical because I tried that about 10 years ago. It suffocates your front desk.
Yeah.
I mean, it's, you know, we all know dental insurance is difficult. Medical insurance is difficult times 20. So what we started to do is to say, we're going to give this to the patients and let you submit it. So what happens is ultimately we get sucked into the discussion because then they want you to go in-network imaging, then they want you to do peer-to-peer reviews on everything. So we just changed a few months ago and we said, you know what? We're going to treat this like we treat implants. We're going to treat this like we treat veneers. We're going to create value for the service. We're going to tell them that dental insurance typically is a relatively low-cost insurance. You're paying $300 to $400 or $500 a year. There's not much there. This is one of the areas that they cut. So we're going to we'll submit, but it doesn't cover much. And that's been a change in our practice. Jeff, I don't know if you and I have talked about this because I've switched that the last few months because what has happened over the last 18 months, the medical insurance company, or the medical insurance world has contracted their coverage. So that's why we've tried to move away from that and move it into a more of an elective type decision for the patient, knowing that they may not get reimbursement. It was creating the same problem I tried years ago. It was killing our front desk.
Mm-hmm.
I mean, you just suck up so much time. You know, we have a busy restorative practice. We can't devote that much time without hiring a separate person for it. And quite frankly, I don't want to do that.
Yeah, I would agree with that. And to me, I would say for most people out there, if they're considering it, I would either outsource it or do it exactly as you are. You just can't burden your front desk with that kind of a thing.
You know, we're generally, most of us are relatively small practices and we're dealing against corporations that are huge.
Mm-hmm.
And we just get swallowed up by it. And you know what? Ultimately, it's not our issue. I hate to, you know, and obviously everyone wants to help their patients, but this is a patient's issue. This is not our issue. Yeah. Our issue is to diagnose and do the best we can to help them make good decisions. Now, I'll do everything I can to help you make a good decision, Mrs. Jones, but if we can't see your anatomy, I can't help you make a good decision. You know, if the patients came in with the same issues at
line in the sand, right?
Mm-hmm.
Do you think an orthopedic physician would have the discussion with them about treatment without seeing the anatomy?
Well, and I think you brought up a valid point. I mean, that's the one thing that Coyce does an amazing job at doing, and you've mentioned it, now you're validating it, is having the patients own the risk, and having them take some ownership in the problem, and that you have the tools and the diagnostic capability to hopefully help find an answer to that problem, but it is their problem. And
the problem is if you don't have the imaging, you don't have the diagnostic tools.
Correct.
You know, it's like the woman who didn't want to start the endo because she didn't have an image of the root anatomy.
Yeah.
We put an appliance in someone thinking they're going to get better. We have no idea the anatomy that we're influencing. Because basically, what does an occlusal appliance do? Occlusal appliance just changes the way the upper and lower jaws contact. So ultimately what it does, it changes the force distribution in the system. That's really what it does. If the tissues that we're changing the force distribution on are compromised, and we're changing the force distribution in a way that may be negative to that, that's a real problem.
Mm-hmm.
You know, ultimately it comes down to, it's a real easy discussion in terms of who needs imaging. If you take a look at the condyle, there's a medial pole and a lateral pole. If the disc isn't covering the medial pole, those are the patients that need imaging. I mean, we make it too difficult. That's really the stripped down version. Either that, or if you have pain greater than a scale of 5 on a scale of 1 to 10. Those are honestly my two parameters. And really, when we talk about medial pole coverage, if the disc comes off, there's going to be a loss of dimension and the bone position is going to change. what's going to happen to the lower incisal edge in that position? It's going to go back, isn't it?
Yeah.
So what's the thickness of the disc?
1.8 millimeters.
So let's be in the load-bearing portion, yes. So let's be generous. Let's call it 2 millimeters, just to be safe. In a seated position, if I'm uncoupled more than the thickness of the disc, does that make sense?
Mhm.
I'm thinking that I've lost the gasket and the bone's repositioned. That's the easiest parameter for imaging. I know generally, to be honest, I know after listening to the history whether they need imaging or not.
I would agree with you. And Jim, we're actually starting to run low on time. We need about 3 more sessions with you.
I'm in.
If you're okay with that. But I've got 2 quick fire questions for you.
Sure.
Really fast. Okay. 1, who's your dental hero?
I have 3 dental heroes. Guy got me into this was Pete Dawson. Pete opened my eyes to occlusion. Pete was a wonderful mentor to me. Pete took me under his wing. Pete encouraged me. Pete supported me. Pete was great. I miss Pete. Pete was awesome. Pete wrote me a beautiful note 3 months before he died. I've got it actually right here on my wall. You can see it right there.
Look at that.
Oh,
So it's, you know.
Jim, I have a picture of you, me, Pete, and Mark Piper at the Equilibration Society.
I remember that picture.
That I cherish. Yeah.
Yeah. My second is Mark Piper. You know, Pete and Mark kind of went hand in hand with me. My third, honestly, is Frank Spear. You know, and the reason I say that is Frank has always been a huge influence on me, but I was never part of the Spear group. But Gary DeWood, who we all know, really talked to Frank about the concepts that we were talking about. And I have to tell you, Frank has been really open in terms of having a teaching center and making a change in his concepts based upon new information. So it takes an egoless person to do that. So I would have to say, I think Frank has really tried to do his best to get the best information out. So, you know, I have tons of other ones, but those would be the big 3 that I've been really lucky. I've been mentored by a lot of great people. So I almost feel like giving those, I'm leaving so many people out, but if I had to choose,
I get it. That's an unfair question.
Those would be the ones but those would be the ones I would say.
Yeah, I get it. And all right, last question.
Yeah.
Lou Malnati's or Giordano's?
Lou Malnati's.
I knew it. Because I've had Lou Malnati's with you.
Here's the secret. Chicago deep dish crust pizza is a media invention. The real Chicago pizza is thin tavern pizza.
Bless you.
I've been living this lie.
Chicago pizza. If you go into the neighborhoods, it's thin crust tavern pizza. And it's awesome. If I have my choice, I would always go thin crust.
Me too.
But if you ask, next time you come to Chicago, I'll take you to a place on the south side where I grew up, Jeff. It's an awesome pizza. Different pizza, but if I had to choose.
Are you Leroy Brown?
That's the southeast side.
Oh, okay.
I was more on the southwest side.
Sorry, I couldn't resist.
But I don't spit into the wind either.
All right, Jim, we got, we ran over, but God, I could talk to you all night. And
me too.
And I actually, I feel bad because I hogged so much of this, and I've had, I've had the pleasure of learning from you and Mark. So, it made the questions really easy, and I could have probably thrown 100 more out. And I just thank you so much from the bottom of my heart for how much you give to dentists and education, and all the dinks out there. Go see Jim. Learn from Jim. He's a true mentor, not just an educator, but a mentor. So, Jim, we're going to let you go. We're going to close it out. But thank you, my friend. It's great to see you.
It's great to see you, and I have to thank you guys. I had a wonderful time, and I would love to come back if you guys want to talk more, but this was so much fun. Thank you guys so much. I really appreciate it.
Well,
Just think of
as
that
soon as
as
we teach
volume
Chad
one.
how to spell meniscus, we'll bring you back.
Yeah.
This disc is easier.
That was volume one, Jim. I can't wait for the rest. Thank you so much.
Thank you guys so much. It was a blast.
All
Night,
right.
Jim. Cheers.
Talk to you guys.
Yeah.
See ya. Cheers.
Cheers. Wow.
Yeah, right?
I'm pretty sure the only time that Chad knew what he was talking about when he was talking about which end of the horse we were looking at.
Yeah.
I got a text like that.
Yeah. No, that was truly fantastic.
That was
I actually,
amazing.
Contrary to popular belief, thank you. I did actually hear Jim speak at the Spear Center a few years ago and just was blown away. I mean, it's like you need to go after you listen to him speak. You just need to go like back to your room and just rest for a while and absorb some of it, because you're gonna. I mean, he's intense and it's fantastic material. It's just he's so full of knowledge. It's
But
amazing.
he's egoless too.
Oh.
And
100%, totally egoless. Yes.
he
Yes.
is not afraid to share his mistakes and
Mhm.
his challenges, and you know that's the making of a great educator.
Yeah. Yeah.
How lucky are we? I feel really blessed to have had this evening with you guys and Jim, and we're
You're-
just really lucky to be able to have
You've
such.
been instructed to say that after every phone call with Chad and I, JB.
Yes, I have. And so I'm just, hold on, let me get my script out. I'm very happy and lucky to be here.
I love it. I love it. Well, guys, what else do we have before we close it out? Next week is Thanksgiving. Thanksgiving.
Thanksgiving. Yay, yay, yay. So I have just a couple of quick things. I don't know if anybody saw the group today, but I started a What You Got Wednesday that's going to be dedicated to education. So that'll be a great spot because we try and steer clear of promotional items except on certain days. So Saturday is obviously the promotional thread day. Let's make Wednesday the What You Got Wednesday, and let's talk about educational events. I know that we've got a lot of great things coming up. Catapult has some great free webinars that are coming up. Viva Learning has several great webinars that are coming up. I got one tomorrow night with them on 3D printing, and then one on Monday on implants for the general practitioner. Jeff, what do you have? You got something going on big this week.
I'm actually going to be at my Piper Study Club this Friday, which I'm really excited about. So I get to hang out with Jim again, and we get to have a lot of joint conversation. So excited about that, and have a big webinar coming up with Midway, with the MEC, Midway Dental Supply. And we're going to be talking about diagnosis. So I'm doing that with Tom Viola, the pharmacologist, and Mark Geisberger. And we're going to really talk about comprehensive diagnosis. So check out the MEC, because that is going to be a great webinar.
JB, what you got coming up?
I have a Mastering the PPO World webinar coming up with the AGD on December 3rd. So all your burning questions about the PPO world, hopefully we'll answer those that night. So there's more information on the AGD website on that.
And I am so proud of you, JB, because the three of us get to do our very first webinar together. And we are going to, December 7th, it's going to be on digital technology. I'm super excited about that. And I can't go without a final shout out. Seattle Study Club joined our group today, and they've got their big symposium coming up. So there's a lot of great education.
That's so nice.
Yeah.
And, you know, just remember, education is truly what keeps us going and keeps feeding us to be better and better every day. Jim was a great example of that. So let's keep making education a cornerstone of this group, and just excited about what we have coming.
Fun
Love it.
stuff. I miss y'all.
Miss you guys too. Oh, wait, I saw Chad this weekend.
Yeah, that's right. Yeah. Yeah.
Hold on, I'm gonna go check my mailbox for the invitation.
Yeah.
Oh, you're such a liar.
Yeah.
No.
We decided that we're going to bring it to
Just kidding.
Raleigh next time.
Next.
Yes.
So at Passover, we always say next year in Jerusalem. And I'm going to say next month in Raleigh.
Next month in
Yay!
Tar Heel
Can't
Nation.
Can't wait.
Yeah.
All right.
All right, guys. I think we need to close it out.
Got it.
Well, have a great evening.
Okay.
See you.
That'll
everybody.
be good. See you on Thanksgiving next week.
Cheers. Can't wait.